Welcome to our podcast, JACC Edge Hyperlipidemia. This is your host, Pratik Doshi. I currently serve as the editor of JACC Edge monthly newsletter, where we do deep dives into hot topics in cardiology. We're very lucky to be joined today by Dr. Harpreet Bhatia, the preventative cardiologist and clinical researcher at the University of California, San Diego, and an expert in hyperlipidemia. Dr. Bhatia completed medical school at Emory, internal medicine at Cornell, where he was also chief resident, and cardiology fellowship at UCSD, where he served as chief fellow and is currently an attending. Dr. Bhatia, we're so happy to have you here in Atlanta.
Thank you so much for having me.
Absolutely. I hope you had your safe travels getting in and are enjoying the Atlanta sun.
Yeah, it's been great. It's a homecoming of sorts to come back to Atlanta, so been enjoying our time here so far. Yeah.
That's awesome. No, I'm happy that you're back, and I'm happy we can have this conversation in this forum.
Yeah, well, thank you for having me. I'm happy to be here.
Yeah. Well, so we asked all of our guests to give a one-liner about themselves, something that they enjoy doing also outside of medicine.
Okay, great. Yeah. So like you said, I'm a preventive cardiologist, clinical researcher. I've been in San Diego almost 6 years now. But outside of medicine and research, I enjoy mostly spending time with my family around different places in San Diego. I have 2 young kids, so that takes up most of our time outside of medicine.
That's fair. And San Diego is probably a nice place to have, the beach and everything.
It's great. Lots of outdoor spaces, theme parks, stuff like that. So lots of stuff for kids. Yeah.
Yeah, a little bit different than New York, for sure.
Yeah, a little different. Yeah.
But to jump into our topic for today, I think the big thing that we're all wondering is about Lp(a). Am I saying that correctly, or is there?
Yeah, so you could say it a lot of different ways. You could say lipoprotein A, lipoprotein(a). I think the easiest is Lpa. So the cleanest way, simplest way to say it.
Yeah. So for the uninitiated, like myself, can you help us understand the research and what makes this biomarker such a risk factor for cardiovascular disease? Just walking us through it.
Absolutely. So there's increasing awareness of lipoprotein A and a lot of interest in it with emerging therapies coming out, but Lpa has been known about for many years, and it's taken a while to get some traction. So I'm happy to see that there's increasing awareness, increasing interest in the area. But to start with sort of the basics, lipoprotein A is a lipoprotein. So it's a cholesterol-carrying particle, carries cholesterol in the circulation. It's similar to LDL, so it has the apolipoprotein B component of LDL, has an additional component called apolipoprotein A, so that's what gives it the name Lpa. So Lpa is sort of a complex particle, and that has a lot of implications for measurement and things like that in therapies. But on a broad scale, Lpa causes cardiovascular disease and multiple cardiovascular disease through multiple mechanisms, which adds to a little bit of the complexity of it, but it leads to atherogenesis, so leads to atherosclerosis. It's pro-inflammatory, and a lot of that is driven by oxidized phospholipids that are carried on the lipoprotein A particle. It's also prothrombotic, and there is sort of less consistent evidence of what exactly causes the prothrombotic mechanism. Part of it may be that it's anti-fibrinolytic because the ApoA component is similar to plasminogen, so sort of competes with plasminogen. And there's also evidence that Lpa has pro-platelet effects. So it can cause disease through multiple mechanisms. It's most strongly associated with coronary disease, or MIs, as well as calcific aortic valve disease. But it's also associated with several other cardiovascular disease, including strokes, heart failure, atrial fibrillation, peripheral arterial disease. Causes a lot of different cardiovascular diseases. It's primarily genetic, so its levels are 80 to 90% determined by the Lpa gene. Most people, or all people, have 2 isoforms, one from each parent, which determine their circulating levels. There are some environmental or other disease states that do influence levels marginally, but it's primarily genetically determined, which is one of the things that makes it very unique. Lifestyle measures, things like that, diet, exercise don't impact it meaningfully. And up to now, there's been a lack of therapies for Lpa specifically, and medical therapies at least. So it's an area where there's a great need for intervention, for treatment. There's also a great need for recognition. So it's estimated that depending on how you define elevated Lpa, it's present in 20 to 30 plus % of the global population at an elevated level, but it's severely under-tested. So We've been part of some studies, and there's a number of other studies that have come out showing rates in general of less than 1% of adult patients getting tested for LPA.
Wow.
We had one study even among people with prior history of cardiovascular disease, less than 3% being tested. So definitely a need for greater recognition to identify these patients.
Yeah. Do you think that part of the lack of testing is a lack of understanding of how to maybe interpret this biomarker?
Absolutely. I think one of the barriers has been, one is there's some degree of lack of awareness, I think, just of it in general and the evidence base. But I think a big barrier is people wonder what you can do about having an elevated LPA, since there are no therapies that are medical therapies specific for LPA yet. The first phase 3 trial of a drug for targeted LPA lowering should complete next year. So that will change. There's also lipoprotein apheresis, which is currently the only therapy that targets LPA and can significantly lower LPA levels. But we believe, there's a lot you can do with that information if you have elevated LPA today, even before those targeted therapies come out.
Can you talk a little bit about that? Because, I think one of the things that I've heard from when I'm talking to, for example, our primary care clinicians is, what is the use of this diagnostic test if I can order a lipid panel instead?
Right. Absolutely.
Yeah.
So one component is, at the minimum, it's a risk enhancer. And so all the major society guidelines at least agree on that. The guidelines all have not yet agreed on universal testing of individuals, although the most recent guidelines have all moved that way, the European guidelines, the Canadian guidelines, and then the NLA guidelines just came out a few days ago, an updated scientific statement that recommended universal screening in all adults. So we're moving that way, but they all agree that LPA increases risk. So even if you don't have a targeted therapy for it, if you take a patient and whether they have elevated LPA or not, that will enhance their risk. And so you can adjust your risk assessment. It might move people from a low risk category or a borderline risk category into an intermediate risk category. So you place them at higher risk, and then you treat them as a higher risk individual. Gotcha. So that's at a minimum. We also know that though lifestyle measures or treating other modifiable risk factors, things like that, do not impact LPA levels, they do impact overall cardiovascular risk. So there has been at least one study showing that if people have better overall cardiovascular health, even if they have elevated LPA levels, they do better if they have better cardiovascular health. Their absolute event rates are still higher than people with lower LPA levels, so there's still a need to treat this residual risk. But still, managing overall cardiovascular health is important, and one of the most potent ways we can do that is LDL lowering. So generally, if I have a patient with elevated LPA, I start by a lot of explanation, kind of the same sort of talk about what it is, what it means.
It sounds like you have this long standing.
I give this talk a lot. Yeah. I think one of the key words to tell people is genetic. So when you tell them it's genetic or runs in families, it's familial, that helps them understand that they can't just modify this on their own, that their risk needs to be aggressively managed. So I start by talking to them about all the traditional sort of modifiable risk factors, trying to make sure those are optimized, including aggressive lowering of LDL-C, because that will reduce their overall cardiovascular risk. Now, statins are still first line for primary prevention in cardiovascular disease, but they do not lower LPA levels. And that's sort of complex to explain to patients, that it's not necessarily the LPA we're going to target, but target your overall risk. Statins may actually increase LPA levels a little bit, but that's probably not very clinically significant. They still reduce the overall risk. But often, if I can, or if patients need more LDL lowering, there is evidence that PCSK9 inhibitors can reduce LPA levels 20 to 30%, and variable response between individuals, but you can see some pronounced reduction in LPA. And there have been analyses from 4AA and from Odyssey Outcomes showing that patients with elevated LPA who were put on PCSK9 inhibitors had an even more pronounced benefit than people with lower LPA levels. So they seem to benefit from that specific LPA lowering. So that's the best sort of medical therapy that we have up to now. And then the other thing I have a sort of a risk-benefit discussion with them about is aspirin therapy. So that's one area that we've been involved in research, is the use of aspirin in primary prevention. The thought behind it is that because LPA sort of doesn't have targeted therapies, this is a higher risk group where we can't address that specific risk as directly as we can, say, with elevated LDL cholesterol or hypertension or other things, diabetes, as well as LPA being prothrombotic, that aspirin might have a specific benefit in these patients. So there's 2 studies of specific single nucleotide polymorphisms of the LPA gene showing that in individuals with those specific SNPs, that aspirin provides a particular benefit, whereas it didn't in the people without those SNPs. So that's in the Women's Health Study, and the Esprit trial was the more recent analysis of that. And then we also showed something similar in MESA, the multi-ethnic study of atherosclerosis, using LPA levels, showing that in individuals with sort of the higher risk elevated LPA levels over 50 milligrams per deciliter, that there was over about a 40 to 50% reduction in cardiovascular risk with aspirin in patients who were taking aspirin. So
that's incredible.
So I present the data. Yeah. So I present the data to people, and there's limitations to it and a lot of caveats. So I give them sort of that discussion, explain the risks and the potential benefits of aspirin therapy.
I mean, I think that brings up a really interesting point. For example, last year we had the pleasure of talking to Dr. Fuster, our former, or outgoing JACC editor. And his big topic of focus over his career has been subclinical disease. And I think things like LPA really drive into that, where you might have a patient with a quote-unquote normal lipid profile, but it sounds like could have an elevated LPA, putting them at very high risk for future thrombotic or embolic events.
Absolutely. So sort of it brings up a couple of different points, but sort of the classic patient I think of is I've had patients like this in their 40s or 50s, otherwise healthy, active, think they eat right, and then they have an MI out of nowhere, and they had never been told their cholesterol was high, their blood pressure was fine, everything seemed to be fine, and they're kind of very surprised, and then you check their LPA, and lo and behold, their LPA is through the roof. And to some degree, it's sort of a relief almost that they know that there was something that caused this, that it didn't just come out of nowhere. And then we can move forward and discuss what to do about it. But certainly LPA is a risk factor for atherosclerosis and for subclinical atherosclerosis that may not always be recognized and is missed in the standard lipid profile. So absolutely, yeah.
Are there I know that we're moving towards universal screening, but in the meantime, if there are certain clinicians that want to be judicious about who they're screening or who they're talking to, are there certain ethnicities, are there certain groups in general that are at higher risk for having elevated LPA? I know you said it's a genetic marker.
Absolutely. So, to start, if we could do universal screening, that would be great, but we do also have to be practical and know that if at the minimum we can hit sort of the higher risk groups, then we'll be doing a better job than we're doing now. One is people with a family history of particularly premature cardiovascular disease, so usually less than 55 in men or less than 65 in women. Those are people who would always want to check LPA. People who've already had an event themselves, particularly at a relatively young age with an absence of other cardiovascular risk factors, that's a group where often you might find an elevated LPA level. There's going to be a higher prevalence of LPA elevation in that population. So those are some groups that you can definitely target. Absolutely, if anyone knows they have a family history of elevated LPA. So it's been shown what we call cascade screening is very high yield. So if you test first or second degree relatives of people with elevated LPA levels, you're going to pick up 40+% of people with elevated LPA. So that's another sort of strategy to sort of pick. Sometimes if I have patients with coronary calcium at a relatively young age, sometimes picked up on a non-gated, just regular chest CT, something like that. Absolutely check LPA, but I do try to check it on everyone. But that's some of the high risk groups to target, and then getting to sort of racial and ethnic groups in large scale studies looking at different racial and ethnic groups. The highest sort of median levels are in Black individuals, followed by South Asians. And so those are definitely groups to pay particular attention to, those tend to have higher LPA levels than other racial and ethnic groups, although there is a need for greater sort of disaggregated data on racial and ethnic groups, but that's sort of our current understanding.
Oh, yeah, I think that's great. At least it helps kind of put a focus on if I'm talking to patients of certain backgrounds or with certain family histories, then maybe LPA is something I want a little bit higher on my workup. So
absolutely,
that's a big risk factor that I think is still probably misunderstood.
Absolutely, and I think it's important too to explain to patients what you're testing and what you're going to do with the information sort of ahead of time. I tell them, it's a genetic risk factor, but what we're testing actually is a simple blood test. It's not a genetic test. So that clears up some confusion too, and it's not, a very expensive test. In my experience, most often it's covered by insurances if you explain sort of the reasoning why you're getting it. And so that helps to clear up some of the barriers. In most individuals, if you use sort of this 80th percentile threshold that we've used historically, and so in 80% of people, you never need to check it again. So it's a very effective test. If, one time you can rule it out. And then if you identify that 20% of individuals with higher levels, then those are the people that you're going to follow more closely going forward.
Yeah, that's fantastic. Any other big pieces of advice you want us to know about hyperlipidemia? I know it's a massive topic and we can write maybe novels and of textbooks about it. But, maybe for the general cardiologist or for the resident/fellow, things that you kind of wish you knew going through this process.
I think, so I'll focus on primary prevention. I think secondary prevention is a little easier. Often if you have someone who's had a MI or stroke in the past, it's easier to get their LDLs to target and get them on appropriate therapy and insurance approvals and things like that. And usually patients are on board with that if they've had a heart attack or something like that before. Primary prevention can be more challenging because you have to do a lot of counseling. So, and there's a wide range of patients. So you'll see patients who have a strong family history or something like that and absolutely want to be aggressive and want to treat things ahead of time before, clinical disease develops. And that's sort of an easier conversation. But then there's patients who are more skeptical of treating something that hasn't happened. And particularly if you're talking about statins, antihypertensive therapies, you're giving them medications that are not going to make them feel any better. And if it works, we'll never really know, we'll just say, oh, you never had an event. Hopefully, the medication helped. So that's a challenging thing. And you kind of have to explain, I think, that paradigm. So what I do is I explain to them how we do risk assessment in primary prevention, how we incorporate sort of these key variables, how we come up with, a 10 or 30-year estimate of their cardiovascular risk. And then that we know, treating these modifiable risk factors accounts for 80 to 90% of cardiovascular disease. And then we can give them sort of estimates. People like numbers, so you can give them estimates of if we put you on a statin, we do things like that, we can lower your overall risk this much. And you kind of have to meet people where they are. Some people will have their own preferences and values, and will make a judgment based on whether they want to be on medication or not. And so all you can do at the end is provide them the information, the counseling, and give them sort of a guidebook to make their own decision on what's best for them. And then I think a big barrier is the perception of statins and the perception of the potential side effects of statins. So many patients, even before trying a statin, are hesitant about trying it. So I often spend a lot of time counseling them on that. Say we can start with low doses. We know a lot of people can tolerate low doses. Moving more towards combination therapy. So if you can use a high potency statin but at a low dose, combine that with ezetimibe, often you can get a more pronounced effect with less side effects. So that's a strategy. And then I say give them contingency plans. If you have muscle pain, if you have an issue with statins, there are other therapies now that are available to us. We have a lot more options than we used to. So things like ezetimibe, bempedoic acid, PCSK9 inhibitors. So I tell them we have to, go with the first line therapy, give it our shot, see if we can get you to where we need to. But we do have other options if that doesn't fail. So if that does fail, so it's worth trying at least, see if you have side effects. We take you off the medication. Most of the time, those side effects are going to go away. So it's a lot of counseling ahead of time, a lot of discussion, a lot of sort of just explanation of the paradigm. Another concept that's harder, I think, for patients to grasp is the idea of a normal cholesterol. They want to know what's a normal LDL-C. And I kind of say there's not really a good answer to that. There are studies, in in children or in babies where they have LDL cholesterol levels, in the 40s or 50s. And so maybe that's an estimate of what's quote unquote normal.
Yeah.
But really I tell them it depends on the context because we know no matter what your LDL cholesterol is, if we lower it, the risk goes down. So if you're at a low risk level to begin with, then we don't necessarily have to do that. But if you're at an intermediate risk or a high risk, even if your LDL cholesterol is, the lab says less than 130 milligrams per deciliter, even if it's in that normal range, we know if we lower it, we're going to lower your risk and hopefully improve your outcomes long term.
Yeah. So what I'm hearing is, even though the EMR doesn't show it in red, we should still talk about it.
Exactly, which is another challenging concept to explain. Yeah.
Yeah. No, I think that's fantastic. It's nice to hear that, the things that we learned about diet, exercise, aspirin therapy, for primary prevention, or statin therapy for primary prevention, as these types of counselings are still as paramount as they were, but now we have better data to kind of inform that conversation moving forward.
Absolutely. I think in general, medicine and in particular cardiology are moving towards more precision medicine. And so there is no one-size-fits-all approach. And I think that helps also with counseling patients. If you explain that we're going to try to target an approach to you specifically, whether it's because of an elevated LPA, whether it's because of coronary calcium or a strong family history, some other risk factors, that we really want to tailor it to that person. And we're not just throwing the kitchen sink at everyone, but we want to look at what your risk factors are and what your values are. Some people want to be on everything, want to treat everything aggressively, want to go down the full line of therapies. Some people want to sort of pick and choose and be more judicious about what they're on. So you have to sort of look at what their risk factors are, judge, is treating their hypertension going to be more important right now versus sort of their borderline LDL-C. Mm-hmm. So a lot of it is really patient-centered care. And you're right, we do have a lot of options. Hyperlipidemia is almost becoming like heart failure now with a sort of a GDMT toolbox of things that we can use. And that's good and bad because it's great because we have a lot of options for patients. On the other hand, it's more pills, so you have to kind of weigh, what the patient wants versus what you think is going to be the best benefit to reduce the risk.
Yeah. No, Dr. Bhatia, I think that's fantastic, and I think all of that information is really going to inform clinical decisions for myself personally, and then hopefully for our listeners as well. I really want to appreciate you and thank you for your time, and it's such a pleasure speaking and learning from you. For more information about hyperlipidemia and LPA, as well as other hot topics in cardiology, please subscribe to the JACC Edge newsletter. For our listeners, this is your host, Pratik Doshi, and I hope to catch you next time on the JACC Edge podcast.